joining another Superior Health Quality Alliance Roundtable conversation. My name is Janae Clements, and I'm joined by my colleague Kim Heft and our guest speaker, Dr. Barbara Resnick from the University of Maryland. For those of you who have been joining these meetings over the past few weeks or even the past year, we'd like to welcome you back. And for those of you who may be new to the call, we're glad that you're here. We host this 1 hour session on the second and fourth Wednesday of the month. The first half of our session will be a didactic presentation, and the remaining half of our session will be left for a Q&A portion. Please remember that these sessions are for you, our audience, so please feel free to take advantage of that chat box and ask any questions or express any concerns or strugglers that you may be facing within your facility. And as a reminder, today's PowerPoint presentation slides will be dropped within the chat momentarily. And the presentation for today will focus on vaccines and updates in older adults. So with that said, Dr. Resnick, I will turn it over to you.
Thanks, and welcome everybody. I'm happy to be here with you. These are just the objectives, and you can look at those yourselves. Go ahead, next slide. Next slide.
Yep, it's all right. It's okay.
So the standards that we really have set for adult immunization practice include 4 things. Very easy. Assess the resident, make a strong recommendation, and I'll be talking more about that. Administer the vaccine or refer to have it administered, and document and report. Next slide. These are just, we won't even take the time to do it because we don't have a setup, but some questions for you to think about as we go through. How much do you need for herd immunity? Next one.
Well, Barb, actually what we could do is, if you don't, we could have the audience put in what they think in chat.
Ah, there you go.
All right, let's do that. So everyone, our audience, what do you think we need for herd immunity? 80%, 85, 90, or 95%? Now, is the answer on the next slide, Barbara?
No, it's not.
Okay, all right, because that's why I wasn't sure if I was going to forward it. So, okay, so we're getting, it looks like we're getting 85, 90. Trying to read them all here. 85s and 90% seem to be the majority thus far on this, not a real poll, but you get what I mean here.
Well, bottom line, you need,
what is it?
You need like 100% for herd immunity. In other words, don't count on it. So
okay.
The higher, the better.
Okay.
So this question is really what statements are true about Medicare coverage. And this one's a little tough right now because it's a bit of a moving target. So I'll tell you at this point, most vaccines are covered. It gets complicated by insurance and other things. So go ahead, next slide. We won't make you answer that one. And what do we know? What's true about vaccinations in long-term care? And you can respond, I guess, with an A, B, C, or D in the chat if you won't, and I'll just reinforce.
Okay, so what do we have here? Which of the following statements about vaccinations in long-term care facilities is true? Facilities are required to offer influenza and pneumonia vaccines to residents, but residents are not required to accept them. Must be vaccinated annually against influenza unless they have medical or religious contraindications. And number 3, health workers in these facilities must be vaccinated annually against influenza unless they have a medical or religious contraindication, or none of the above. All right, so
it looks to me like most people got it.
Yes.
We have to offer, but we can't force. That day may come, but it's not here yet. Next slide. So what's really currently happening, and are there needs and opportunities? So really one of the things that always drives me crazy is there's no requirements that residents in assisted living, senior housing, retirement communities, or continuing care retirement communities be immunized. Children can go to school as long as they don't have, I'm sorry, not children, I'm making a joke. Older adults can go to school, live in facilities as long as they don't have TB, but we don't worry about immunizations. And again, that's a surprising thing. Some states are beginning to move in that direction with regard to AL, but really nothing else. Next slide. About an estimated 40 to 50,000 adults die each year from vaccine preventable diseases. 1 million adults get shingles, which is horrific. And direct healthcare costs associated with these diseases are approximately 10 billion each year. Next slide. Influenza also affects older adults disproportionately. There are 23,000 influenza-related deaths, and 90% are in older adults, let alone the acute respiratory failure, as well as cardiovascular events and changes in function. Strep pneumonia is the most common cause of community-acquired pneumonia, and there's about over 43,000 cases per year, 5,000 deaths. The majority, again, are in older adults. Does it matter? Well, the rate of influenza and pneumonia vaccine across all races and ethnicities was approximately 60% in terms of getting immunized. For tetanus, the rate was similar, about 55%. Although for tetanus combined with pertussis, it's really low, maybe a little bit better over the last year because, you know, you never catch up with the data, but it's only been about 8%. Shingles has also been very low, maybe a little bit better today, but generally around 20%. And this is all in contrast to the goals of Healthy People 2030, which is to get immunizations up to 90%. So it matters, and we still have room to go. Next slide. Adults who are not immunized not only can become ill themselves, but of course it's the transmittal to others. And that's, particularly true with our concerns over pertussis, because we don't want grandma to be giving it to her grandchildren. Next slide. Nothing is perfect. Nothing is 100% effective, but immunization is the best thing we have to help prevent disease. And the CDC recommends routine administration of pneumococcal for all adults 65 years of age or older. And the vaccine against herpes zoster is 90% effective. I mean, who wouldn't go for 90% to avoid the pain that can happen with regard to shingles? And it does reduce the risk as well of having post-traumatic neuralgia, the gift that keeps on giving. Next slide. Zoster is quite common. It still affects about 50% of those who are 85 years of age and older, and we have no idea why it happens. And then the incident of it hanging on, the pain hanging on, is about 15%. And aside from the negative impact of pain from zoster, either acute or chronic immunization will decrease the risk of also having to isolate people during that period of illness, which can be a couple of weeks and can be very upsetting for some residents, particularly people with cognitive impairment. Next slide. This is just the guideline. Again, you can Google this or you'll have it in the slides. These are the current guidelines for immunization for people, older adults as well as younger. Next slide. You can go again. It's just continuation. So pneumonia vaccines at 65 and older. It's a little confusing, but the recommendation is to give 1 dose of the PCV15 or PCV20. If the PCV15 is used, you have to follow it by a dose of the PPSV23 at least a year later, or at least wait 8 weeks. If the PCV20 is used, then you don't have to give the PPSV23. Those additional 3 areas of coverage are not critical. Next slide. For adults 65 and older who have only received the PPSV23, CDC has additional recommendations that you give the PCV15 or 20 to get a little additional coverage, and that should be given at least 1 year after PPSV23 is given. Regardless, you don't have to do a second pneumonia vaccine. So if somebody's had the PPSV23, you don't give that again. Next slide. For adults 65 and older who only have received the PCV13, then you need to give the PPSV23. For adults who have received the 13 but haven't completed their recommended pneumonial vaccines, with the 23, 1 dose of 20 can be used if you don't have the PPSV23. If the 20, so it is confusing, and I got to tell you, most people don't even know if they've had a pneumonia vaccine, let alone which one. So it's a tough one. The important thing to remember, if somebody's not sure, you go with the default by the CDC, which is to give. And just go with the philosophy, it's better to give something than nothing at all. And if you're not sure, give. Next slide, kind of like donations, right? Flu vaccine. Currently licensed influenza vaccine products are classified as inactivated influenza vaccine, live attenuated influenza vaccine, and recombinant influenza vaccine. The inactivated is the only one that's approved for older adults. It's given intramuscularly, and there are 3 different strains that have been included. Next slide. So if you choose just 1 strain of B, that can lead to a gap in coverage. And that's why now we have, let's say, bigger and better vaccines. In 2013, the quadrivalent influenza vaccine was approved for use. And now we know there's also the high dose formulation for older adults. So it gives more of the amount of the vaccine, because as we get older, we need a greater stimulus of anything, whether it's what you're eating, seeing, or hearing. It's also what you're getting in a vaccine. And that's the reason for the higher dose. At the same time, that higher dose hurts a little bit more, let's be honest. Next slide. The virus for inactivated influenza vaccine is grown in eggs. It is now I don't know what happened there. It's no longer a problem. You can give people who have egg allergies vaccines, and they don't have to be like in a hospital. Next slide. Current advisory committee on immunization practice now recommends either giving a standard inactivated influenza, the trivalent or the quadrivalent, or high dose. So you can give any one of those. Again, I'm going to stress the default here is if you don't have one of these, say your facility won't pay for one of these, give what you've got. It's better than nothing. Next slide. And that's not coming from me, that's CDC recommendation. With the pneumonia vaccine, we've talked a lot about this, but there's the pneumonia polysaccharide vaccine and the pneumonia conjugate vaccine. The number at the end indicates how many capsular subtypes are covered. Next slide. This is just some history, and I think we can just go through those because we went through all the gory details of the different types of pneumonia vaccines and that the challenge. Next slide.
Barbara, real quick, it says here the first pneumonia vaccine was established in 1818. That does not say 18. It says 1983.
Yeah.
Has the efficacy been the same since then? Has it, or has it gotten better?
No, I don't believe it's gotten better. I don't know the exact answer for that, but in fact, that's why we added some of the other ones. And the history behind the adding the other ones was sort of interesting because a couple of years it came out that it was required. And then there was pedaling back because it really showed it didn't make that much difference. And so it's no longer required that you give both the PPS 23 plus the 13 was what we were requiring. And then it became shared decision making, but the recommendations just changed again to what I shared earlier. Pneumonia, I find to be very, very confusing for people. And as I said, I find most people don't even know if they had a pneumonia vaccine, let alone what it is.
Thanks. Thank you for that, Barbara. And since we're just talking about the Pneumovac, Janae is going to be putting a link into chat on the Pneumovac recommendations app. It's an app made by the CDC so that if someone says they never had the vaccine, you just put that in and then it spits out what they should have. Or if they got this, then it tells you they should have that. So we're going to be dropping that in chat here in a second. So just wanted to let you know that. And Barbara, we're going to keep moving. Sorry about that.
That's quite all right. And as this, just the most important point is, if you're not sure, give.
Oh, okay. Thank you.
Shingles. So shingles is one of my probably biggest pushes because I think like really it's so horrible. I'm a nurse practitioner, so I've seen all too many shingles cases and it can just be devastating. I mean, some people dive out their own windows from the pain. So Shingrix is a live attenuated virus. The vaccine reduces the incidence of shingles anywhere from 50 to 90%. It was 50% with Shingrix. The newer one, Shingrix, is 90%. And again, reduces your risk of long-term pain. Next slide. Shingrix, again, indicated now for anybody 50 or older, and it is not indicated for prevention of chickenpox. Next slide. Very similar reasons why you can't have it if you've had reactions previously. And it's just a one-time experience, a one-time event, although there is a 2-shot series. Side effects, mostly just local discomfort. Next slide. Go ahead, next slide. These are just again, the recommendations. It's a little complicated to give. It does need to be refrigerated. It has to be stored and that kind of thing, but not quite as complicated as the earlier Shingrix was, which is great. We bring it into senior housing facilities, no problem. and get folks administered. The second dose needs to be given anytime between 2 and 6 months after the first dose. So it is keeping people on track. And there was a lot of difficulty around that because of COVID. Next slide. This is just billing for those that are interested, how you can bill for giving immunizations. Next slide. The ACIP guidelines were established in 2008, and these just provide routine immunization for adults over 60. And again, highly recommended to give the shingles vaccine. Next slide. TDP. Since the beginning of the 21st century, there's been a rise in the cases of pertussis. I know we don't really see or feel it necessarily, but there are up to 48,000 cases in 2012. Part of the reason is a decrease in childhood immunizations. The change from the use of a whole cell pertussis to acellular pertussis, which has a shorter duration of protection. And that's what led to some of the changes in the recommendations for the Tdap booster. Next slide. So it is now recommended that there be a one-time Tdap booster for all adults, really to protect the adults, but probably more so their kids. And Tdap can be given at any time, and then continue with the routine tetanus immunization every 10 years. This is just a review of recommendations. Again, I just can't stress enough, if in doubt, immunize. COVID, I think, well, basically, if you listen to the news today, you're going to get another one. Number 5 is coming out this fall, so get ready. Don't hide, get ready. Next slide. So what is your job in immunizations? First of all, it's to assess, to figure out what those you provide care for are getting, have gotten, doing the best, I'm going to say, detective work you can do. Next slide. What do you do with the information? Well, you don't just check it off. You need to think about what you're going to do with it. And we recognize there are a lot of barriers to immunization. You may have a lack of infrastructure. We don't have regulations like they do for schools. Some states have more than others. Some facilities have more than others. Next slide. There's generally no similar incentive for adults or impetus to get immunized. Nursing homes actually have it better than other places, truthfully, because there is that requirement at least to ask, offer and ask. Next slide. Access. A growing number of pharmacists now administer vaccines, and some people in some states are looking at lots of other ways. Nursing assistants to be able to, hairdressers, other sites that people go to, and increase coverage. Next slide. The lack of a guaranteed source of payment for vaccines is certainly a concern, and we'll probably hear more and more about that in the coming year. Next slide. In all honesty, healthcare providers are actually really bad examples. Often healthcare providers refuse to get immunized. Nurses used to have a very low rate. I think with COVID, it may have gotten a little bit better. Unfortunately, I think the nurses see some of the bad local reactions to immunizations and get scared. But immunizations are particularly important for those of us that are healthcare providers so that we don't spread disease as well as we maintain our own health. Next slide. What can you do to overcome the challenges? Well, I think one of the most important things we can do is do a little more telling than asking. And we'll talk more about that. But you want to tell residents and families you're administering vaccines as per recommendations of the CDC, unless they refuse. Next slide. It gives them the opportunity for the out, but it's sending a different message. If you need to, you can work with a local pharmacy and prearrange delivery and storage and reconstitution of the vaccine. Zoster is a good example where that needs to be done. Next slide. Coverage, again, it's generally covered at this point in time. Even Zoster is easier to get covered now. Next slide. These are just some resources that you can access to get more information about CDC guidelines and other groups. They generally all coalesce around the same message. Next slide. So I really encourage you to think about taking on the challenge, and it really takes a champion within a facility to lead the way on immunizations, be passionate about it, to gather a team to help you, establish the barriers and challenges and ways to overcome them, and then make it. So a champion might just be somebody that really has a passion for vaccines, somebody that you assign to have a passion, but it is best if it comes from within. Next slide. And the team is generally, whether it's office staff if you're in an office, but the DON, an AL manager, depends what setting you're in, and then bringing in others. Talked about what to assess, and it's really asking about vaccine status. If it's moving into a facility, it might just be at the time of admission. If you're in a primary care practice or seeing patients or residents that come in and out, it's every time you have exposure. It might be every time you have the opportunity to talk to a family member. And again, particularly if they've refused once. There is no law against asking. Next slide. Consider what's currently in place in your practice or in your facility. What do you currently do? How could you maybe get that ask or that assessment out there better? Are you capturing it in the electronic database, or is it just like, I don't know, I asked them, but I'm not sure where I put that information. Next slide. Administer or refer. Again, if you have the opportunity, just give it. And for example, flu, I think flu vaccines, we tend to keep a stash of them for a while. And as new residents move in, you just give it. Same with pneumonia, which can be given anytime. Shingles you can't really keep hanging around, but you can arrange a delivery. So it's thinking about how quick you can get it in. I remember with COVID, my gosh, we used to walk people to, not literally walk, but push in a wheelchair sometimes if you have a pharmacy nearby, right? Somehow to get that person immunized. Next slide. And then thinking about really thinking out of the box. how can you work with your pharmacy to make it happen better and easier? Next slide. Education of staff. Knowledge doesn't change behavior, but even for their own immunizations, doing some education about the benefit, and you just can never say it so much. It's saying it, giving resources, and really one of the best things is meeting with individuals one-on-one to see why they won't or they're choosing not to get immunized, and seeing if you can help overcome some of those challenges. And there's many ways, whether it's, people's stories, etc. Next step, next slide. Documenting and reporting. Again, making sure you document the what, when, how, and who of immunizing people, and that is required by law. Next slide. You are supposed to as well provide information to residents or their proxy about the immunization, and then document your 5 facts: the date, the manufacturer, the lot number, name, address, and signature of the person who gives it, the addition of the information given, and this is all online in this at the CDC, and the date it was given to the resident or the proxy, and then to report to your state what the resident's personal vaccination record is. Next slide. Go ahead, just go to next slide.
Did I? Oh, okay.
No, you're good. Just go ahead, next slide.
Okay.
It's really the
I'll put them all out.
Thanks, going slow.
All right, we'll get them all out here. All right, let me move that one. Right, there we go. Okay.
The next thing is really measuring your progress and documenting that. Next slide, because this is really the thinking about how you're going to get the information back to your residents. I think family members like to know, oh my gosh, we had 100% immunization against flu. Whatever it is, you really want to get that progress back to your staff as well as all the stakeholders. Next slide. There may be more. Again, using your EMR. Depending on what your barriers and challenges are, it's really identifying the solutions, thinking through what can we do to overcome, whether it's access, whether it's challenges in terms of documentation. This year, bet you anything, it's going to be getting staff in there to help with immunizations. So thinking about how you can overcome that. Maybe get some nursing and pharmacy students in there. Next slide. I think, so we have time for questions. This is just a case example that you can all go through on your own. Really talks about how we implement a intervention to improve immunizations. In this case, it was in assisted living. And it really goes through the process of those steps I talked to you about, identifying that champion and having the champion do some of the education, working with your staff, mentoring and motivating, and getting as many as possible immunized. You can
Is
probably,
this okay?
Yeah, everybody can go through that on your own. It goes through because it's a bit of a long case. I can't really tell what time, but I think you wanted to leave time for questions. Otherwise, I'm happy to go through the case. Or maybe people could share their own experiences with immunizations and either things that they've done successfully or challenges they've had, and we can brainstorm together on how to solve them.
That
Yeah,
would be,
Kim, it looks like we have a question there in the chat. Will there be a VIS form for the COVID vaccines? Dr. Resnick, I'm not sure if you can speak to that or not.
Should be, and it's an excellent question. We'll have to check with the CDC, and I would say, will there be one? Because each COVID immunization actually needs a new one.
yeah, I wouldn't doubt if that gets updated, like you just said, with all
Yeah.
of the other ones from before.
Yeah, I'm
They have-
anticipating. Mhm.
And they have been emergency use authorizations too.
Yeah.
They haven't necessarily been the actual VIS that's been used.
Right.
If that's correct. Correct. Yes.
Correct.
So I'm
Correct.
sure that will come too.
Yeah, and I think particularly with the expectation with the one in the fall, I think there will be information, but I have not seen anything yet.
Yeah, for those of you that were not aware, Dr. Resnick just did mention that just yesterday, the new COVID monovalent vaccine has been approved by the CDC, and anyone ages 6 months and over, that's the recommendation for getting that. I know that we haven't, we're still waiting to hear, exactly what the up-to-date definition is going to be for our work here that we do in nursing homes, long-term care, and SNFs. But I wouldn't doubt, unless somebody else has something different, that up-to-date will probably mean getting this new monovalent vaccine that was just approved yesterday.
It's going to get probably quite confusing because people don't even always remember and keep a good track of how many COVID boosters they've had along the way.
Well, hopefully this will be, I've heard, again, this is all speculation that, just little bits and pieces you read here and there, that it would maybe be nice to hear that the COVID.
Oh,
Kim, I think we lost you.
or yeah, she froze. I can't tell, Janae, if there's any other questions.
Yeah, I mean, the floor is open. Please feel free to take advantage of the chat box if anyone has any questions, or feel free to come off of mute.
Or experiences. I mean,
Yeah,
great examples you can share with colleagues about ways you've done it well. I mean, either I would say either with staff or with residents. There's some, interesting, well-established approaches for how to get staff immunized, some tricks of the trade. So anything we like to share, I'm happy to share some of the things that I've seen that have been effective, but would love to hear from others. So don't be so shy.
I think the biggest question that has been raised around long-term care facilities has been around hesitancy of, and so forth, and having to navigate those conversations. What advice do you have when you have a population that is, whether it's the family or the resident, is they have vaccine hesitancies, or they have conspiracy theories? So what can we do as clinicians?
Yep. So my area of research is actually motivation, whether it's exercise, vaccines, whatever it is, right? And so I think the most important thing there is to never stop trying. The hesitancy and the beliefs people have are really hard to overcome. I get it. But our job is to ask, kind of always like the 2-year-old, but why? What is it that makes you fearful? What is it that makes you not want to get immunized? And just going through again the same that we have about immunizations. We're not going to win every case, but it is amazing how many times I have been able to bring people around. It may not be the first interaction, it may take a couple, but I always say never give up. That's the most important thing. And for those that are not quite so dug in, it is probably the best thing you can do is not ask, but tell. And William Schaffner, who you probably see often quoted in the area of immunizations, his big thing is always just tell them you're doing it today and walk in with that needle, right? Catching them when you can. But I appreciate the fact we won't get them all, but keep trying. Education, as I said, doesn't change behavior. Helping with facts, stories, those are also quite helpful. I wish there was a magic pill, but there's not. For staff, there are, there's a few things also to make sure that we do, and that is making it easy for staff to get immunized, even to the point of don't make them go to the furthest end of the facility, right? Because the motivation to walk there could be a challenge. So it's things, offering it frequently, that kind of thing.
That's a great thought. Any other questions lingering out there this afternoon? Oh, Kim, looks like Kim made it back online. Okay.
And I was just not there anymore.
Yeah, you just froze.
So yes, not quite sure what you had just spoke about, Dr. Resnick. One question I had on my mind, and if you already answered it, that's fine. But are there barriers that you frequently see? What are your top couple of barriers you see, and what strategies have worked on those barriers? Maybe that was already discussed.
Well, we talked about people with significant hesitancy. So that is one of the barriers. And then I just raised with staff making it easy. But, I think the biggest barriers for all of us are some of the beliefs that people get and hang on to. I think that would probably be number one. And my response I just shared is really to just keep addressing that and try and get past what's an excuse versus what's a real barrier. Because for example, somebody may say, oh, geez, I just really haven't had the time. But it's like, I'm not believing that. You had time to go to the movies this weekend. Don't tell me you didn't have time to get immunized, right? So it's digging beneath what might be a superficial, socially acceptable excuse and get to what the real barriers are. Some of it is people are afraid of the pain. Those are always the funniest to me. Like, really? You're 7'2" and you're afraid of a little needle? But this is an issue. I mean, for more people than you realize. I just heard one of my grandkids was just saying, I'd rather get the flu than get vaccinated because of the shot, right? Well, he got a little check from grandma. Sure. About what having the flu could mean for him and everybody in his family, and BB and Zadie as well, right? So it's get deeper, really go for the why, and then try and work through it. Hesitancy is a real challenging one, as are the crazy ideas. I had a patient that absolutely refused to get a flu shot because it gave her arthritis. Now, seriously, let me tell you, she was 95 years old. Do you think she got arthritis from a flu shot? But when COVID came, she was willing to get immunized from COVID. because of the fear of the disease. So that's the other thing, is if you can't get rid of the crazy beliefs, help people understand the benefit, because you're weighing the plus minus here. And a lot of what people don't understand, particularly around flu, pneumonia, well, all of them, truthfully, is the impact on cardiovascular disease. And Stefan Gravenstein's work, for those of you who haven't read it, I mean, has shown repeatedly the impact on cardiovascular disease if you get flu, pneumonia. Obviously, COVID, we've heard more about, but even flu and pneumonia, it's what happens after. It's not just that infection, it's what's down the road. And older adults don't want to have strokes, particularly. Heart attack, if you can promise them they'll go to heaven after, it might be one thing. But strokes, you know, and living through it, no one wants. So really thinking about what might get that person to turn over. And then really it is making it easy. You know, if it's a pain in the neck to get to a pharmacy, to enroll in a pharmacy, blah, 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 blah. In senior housing, we bring the immunizations to them because they ain't going out or they can't get out. And, you know, in nursing homes, we're often able to do that. You can work within your pharmacies and get that help, get that access. So it's thinking about those things, and the same with staff, because the issues are the same. They really are. And make it required, make it law, and it changes behavior, doesn't it? And I know there's lots of debates about that, and we could go on, but there are some facilities that are requiring it. And we really have not seen that you lose that many staff if you require.
It looks like we have some more questions here in the chat. Angie says, I completely agree with you. We have been most successful with the flu shot when we have offered the vaccine, unless they decline with the COVID-19 vaccine requiring written consent. Is this an option? Angie, I'm not sure I fully understand your question. Are you just referring to whether you need to have that written consent there or not? Please feel free to come off mute or just clarify for me in the chat.
But
Yes,
I would say regardless.
Yes.
Yeah.
Go ahead, Dr. Argus.
What we recommend is when people move in, get blanket consent for all immunizations. Just have them sign right then and there, and then you don't have to do it every year, every time. And you can just tell them mom's been immunized. So you can get blanket consent for all, say, all CDC recommended immunizations.
It looks like Sharon says, just curious about the app you were talking about. I believe it was that CDC app.
Mm-hmm.
Are you familiar with that one, Dr. Resnick?
I had not seen that before, so I don't know if
Kim,
yeah,
speak to that.
Yeah, sure. If you if you
I will
could
put it in the chat again.
if you could drop it again for me, please, Janae.
Yeah.
This particular app is only for the pneumococcal vaccination. It's not for all of the vaccinations. It's just the one, because you saw as Barbara's going through the slides, you're just like, wait, I'm lost. Which one should I give? So this is a helpful tool that you can plug in what you know about the resident status, and it will then tell you what the recommendations are based on what you put into that application. So the other thing I just wanted to mention real quick, again, sorry if it was already said, I'm hearing a lot about, you know, like, yeah, I don't have enough time. We have all these vaccinations to give, especially coming up. We just got an RSV vaccine came out. Then you have the COVID, now the influenza, and all these winter activities, right? Fall, winter diseases that could just pop up at any moment, and we don't have the staff. We don't have the time. We realize that here at Superior Health, and we've talked to a lot of you and other nursing homes. We do have a way to help you out with mobile vaccination clinics. They're free for you in Michigan, and we're working on also developing this in Minnesota and Wisconsin. Now, wait, before you say, I have to take back what I said a little bit. I do also have vaccination clinics for Minnesota and Wisconsin. We have them, but we're also working on a third that may also move out of Michigan and go into those two areas also. Bottom line, we can help. So if you don't have like the resources, the time, the supplies for like the influenza and especially the new COVID vaccine coming in, give me a ring. Well, maybe not a ring, but here's my email address so that we can help you out, set something up for that.
Say anybody can feel free to pop me an email, and if I don't know it, I'll help you get the information.
I have a quick question. It may have been answered. I've kind of been popping in and out, but the new COVID vaccine, the monovalent that's coming out, is it replacing the bivalent? Will the bivalent go away like the original monovalents did, or what's the scoop here?
I believe that's the plan, but I'm not sure that that's clear yet, but that's the
Okay.
impression I have. Yeah.
Okay.
I agree, Stace, with Barbara that the newest one that was just approved by the guidance that was given out by the CDC yesterday will be the only one available, I believe.
More to learn about that in the coming weeks.
I have a question about that. Do you know if the new monovalent has to be separated by like 4 months or 6 months if they happen to have had a bivalent booster recently? We've had a couple admissions that actually had their second bivalent, so they wouldn't be out of that window. Just wondering.
You know, it's a good question. I am not sure at this point.
Okay.
Again, I think we'll.
Yeah, I was going to share, I did on the, out of Minnesota, the state of Minnesota, it said 2 months since most recent
Oh,
vaccine.
Okay, that's a good rule of thumb.
Yeah.
Yeah, if you go on the CDC, what it means to be up to date, COVID up to date. I don't have, I know I have a co-partner here on this call that probably can drop that in the chat pretty darn quick. But it's the up-to-date definition by the CDC. In fact, they just even released quickly. They released just this morning about the new recommendations. But if you go CDC up to date, and then it should have some more information for you. And I would not doubt that yes, this is going to, the new vaccine will have to be separated by 2 months. You're right. I don't know that for sure, but if Minnesota put that out already, was it this the health department in Minnesota, Angie?
Oh, that wasn't me. That was
Oh,
Stacy.
I'm sorry, Amanda.
It was Stacy. Yes, it came from the
Sorry,
Minnesota
Stacey.
Department of Health.
Yes, yes. That I wouldn't doubt they just got that from the CDC.
Okay.
Yes, and here is the new CDC up-to-date vaccine information is also in chat here for you.
Okay.
Janae, do you want to close us out?
Yeah, it looks like we don't have any more questions in the chat. So Dr. Resnick, we greatly appreciate your time and your informative presentation. To all of our viewers, it looks like, pulling up the schedule here, we will be meeting on the 27th of this month, and our topic will be infection control and immunizations. Together, we can fight infection. So we look forward to that. And with that, I hope everybody has a great rest of your day, and we will see you in the next couple of weeks.